early on in my tenure as director of the breast program was I would get complaints. I don't know, I'd say at least every 3 months or so I would get an upset patient because they had seen their surgeon and the surgeon would say they were done, the margins were adequate, and they could move on to their next phase of care, and they would show up in the medical oncologist's office, and the medical oncologist would say, well, you know, the margin's really a little too close. I think you need to go back for a re-excision. And that was incredibly unsettling for the patient.
Comprehensive breast program did not exist when I first started here. Actually, in the sort of section of general surgery, we had 6 surgeons at that time, and all 6 did everything.
One of the first things I did was conduct some focus groups of patients to try and understand really where we were falling short. And the message came across loud and clear on some of the issues around care coordination and communication across the provider groups. There are at least 5 specialties involved in breast cancer care: radiology, plastic surgery, breast oncology, medical oncology, pathology, radiation oncology, and they're all geographically diverse. They all have different administrative support. The doctors, don't cross paths often enough, and patients would complete one phase and be told, the next phase is with another group. But patients would come in through one of those 5 or 6 departments. They would be asked to bring in their outside information, and each time they came back, they would be asked to bring in their outside information and make their own telephone calls for the next appointments. There wasn't necessarily a smooth handoff, so patients might slip through the cracks and not actually make it to the next step in their care process. It's the structure of medical care. It's been based on specialty and not on patient groups. So if we design care around breast cancer, it'd be very different. The groups of people that come together would be very different. But pathologists train pathologists, and pathologists do lung cancer and breast cancer and bone cancer, and plastic surgeons do cosmetic surgery and breast reconstruction and craniofacial surgery, and so our silos are defined by our specialty, which is much broader than a single disease or patient group. If you're a technologist in radiation oncology, you don't know what happens in radiology, you don't know what happens in the OR room, you don't know what happens in all these different steps. It's all like a black box to you. All you know is you're going to do some radiation planning and delivery. But not knowing what the patient's been through before that, I think, doesn't allow you to provide them with as much guidance as you could, or for you to have as much understanding about your role in that and the importance of what you're doing.
I think the main thing is that when patients get diagnosed with something like this, they want everything done yesterday, pretty much.
I think the most difficult period of time is between when you get the initial diagnosis and you start treatment, and whether it's a week or 2 or a month, while plans are being made, there's this unknown, and you're not doing anything but waiting, and that's the most difficult period. And I find talking to women during that time can be most helpful to them, and to acknowledge that they are in the hardest part of breast cancer. As soon as your treatment starts, as soon as you have your surgery, as soon as something's being done, you're going to feel this. You may feel sick, you may feel uncomfortable, but you'll have huge emotional relief that finally you're on your way towards dealing with this news.